Thank you. Of course, I also want to thank the ISPN to organize this very special meeting in these special times, and thank Francesco for inviting me to share some thoughts on fetoscopy with a very challenging title, Fetoscopy or Open Surgery. Same results, same surgeons, same patients. I'll first give a short introduction of our experience at the moment. We have a lot of open cases, but only 3 fetoscopies. Then I'll consider results, surgeons, and patients, and I'll end with some thoughts about the future. Very important to me, fetal surgery is not only fetal surgery, but it's also maternal surgery, and fetal surgery is teamwork. And I've showed this. This is not me, this is, I don't know who, but it's like in a time trial, you have someone in front and you have a lot of following. In Leuven, Jan Deprest, the obstetrician, is the most important person in the team. For the first cases, we collaborated first with Philadelphia, then with Zurich for a few cases, and for the 3 fetoscopic cases, Michael Belfort came to Leuven to help us with those. We are working together, like Dominic said, with London. In Leuven, we started in August 2012, and we have at the moment 75 open cases and 3 fetoscopic cases. The neurosurgeons, myself and Philippe de Vloo. And in London, we started in June 2018. First case was done, and Jan Deprest told me a few days ago that in London they've done 16 cases. Correct me if I'm wrong, Dominic. Last year, Leuven and UCLH were designated as the 2 British centers for fetal surgery, which is very special, British NHS center on the continent, and is going to persist even after Brexit. Our patients come from a bit everywhere in Europe, most from United Kingdom, then Holland, then from Belgium, and then few from several different countries, 1 person from the USA and 3 from Australia. Our technique follows the published MOMS trial technique with some small modifications, and in recent years, like Dominic has said, we moved to a small opening in the uterus, about 4 centimeters, mini hysterotomy. Fetal surgical time is less than 1 hour, neurulation in 1 in 3. Closing the dura is not always possible. Most water tightness comes from closure of the fascia, but fascia and skin are usually of very good quality, and this is important also with the implications for fetoscopic closure. These are some early cases, and this is a later case with a smaller uterine opening. One other thing that we see is that the skin heals usually very well if you are able to close it in a linear fashion. In about 20%, we had to use patch because we were not able to close the skin. This is also as efficient, but probably the scars in the long term will not be so good. We've always done MR after 6 or 7 days, and this is also important. You've seen Michel and Dominique showing the same, but I think Chiari is absolutely always present when you have a myelomeningocele, and the reversal, complete or partial reversal of the Chiari, is a very important quality parameter of the surgery. It it should be better after the surgery. Fetoscopy, we've only done 3 cases with the technique of Houston, and we had planned to do more cases, but because the Houston people were not able to come to Leuven, we had to abort those and do open, because we think that 3 cases is not enough to start doing it on yourself. So now we come to the main point. Are the results of fetoscopy the same as the results of open repair? This is a dramatic case that we, because of brain abnormalities, did not want to do an open surgery, and the mother went to another center where there was endoscopy done, coverage, patch coverage. When the child was 3 months old, it came back and you could still see the placode at the level of the skin. So this looks more like the way it was done in Roman and medieval times than in the 21st century. This is not the way to do it. When you do fetoscopy, your aims are to reduce morbidity for the mother, the laparotomy, for the uterus, and for the fetus. And you want to have at least the same neuroprotective effects as in the published open fetal repair. So the tonsillar herniation, the hydrocephalus, the level of deficit, the percentage of children walking, and also the later occurrence of tethering and inclusion dermoid cysts. All these have to be the same or better than in the open repair. Dominic has already shown that there are many different fetoscopic techniques. This is still evolving, and at the moment, the Houston technique of Belfort and Whitehead is, I think, the best published technique. In 2016, Luc Joyeux did a systematic review. At that time, fetoscopic surgery was usually patch coverage, and then in this systematic review, it was clearly worse than the published MMC results. 4 years later, because of these technical improvements, we see much less prematurity, similar outcomes, and less maternal morbidity. So when you make a comparison, you do not always compare with published results because the technique is evolving so rapidly. What are the conclusions on the results? There is consensus, there is high evidence that the morbidity for the mother and the uterus is less. There is some evidence that the morbidity for the fetus may be less, but that the neurological outcome is the same needs to be confirmed by other groups by larger numbers. Second question, fetoscopy and open repair, are these the same surgeons? And there the answer is clearly no. I will talk about 2 things. The first is the learning curves, like we published this year. When you do a hysterotomy and an open repair, competence is reached after more or less 30 cases. For fetoscopy, you need more cases before you reach a competent level of surgical skill in doing this procedure. The statistics of this article show that a learning curve exists, that you need large numbers, just like you would need for operating an aneurysm or a meningioma, and that the point of competence in open surgery is reached somewhat more quickly than after fetoscopy. There are training models, there are several training models. Texan training model. Luc Joyeux developed a model on the stomach of a rabbit. And of course, if you are very rich, you can do lamb surgery, which most closely resembles a human fetus. This is unpublished yet, but the different steps of fetoscopic repair compared to the steps in this rabbit stomach. So what are my conclusions on surgeons? Neurosurgeons, and we are all neurosurgeons who do endoscopy in the ventricles, but we are not used to doing 3-port endoscopy where an assistant handles a camera and where you make sutures, and so we are at a disadvantage compared to surgeons who often do laparoscopic techniques, removing gallbladders, for instance. We are not used to do this. Second thing is, even though we are not used to doing this, we are much more experienced in the anatomy of the spinal cord, in making the distinction between LDM and myelomeningocele, and we know what happens with those children when they are growing, when they need all kinds of interventions, tethered cord, wheelchairs, etc. The other thing is, because of the numbers necessary to gain competence, and it has been said, centralization is necessary. You do not, the fact that you have class 1 evidence from the MOMS trial does not mean that everyone can do it. You need large numbers to be able to offer the patients the care that they really deserve. And as I said, the training model can help to develop the skills. Last, same patients. And as I said, fetal surgery is not fetal surgery, but is fetal maternal surgery. So there are 2 points. First, the fetus. I don't have scientific data, just some thoughts, but fetoscopy, when you look at the published series and when you hear what some colleagues say, fetoscopy is often done quite late, 29, 30 weeks. And as Dominic has already shown the slide from Fabio Peralta, the benefit for the fetus becomes smaller the later that you do this procedure. How late is still meaningful? Nobody really knows this, but it is clear that the earlier, the more benefits. For the mothers, it's the same. Fetoscopy is without doubt less invasive. You can extend the technique to more people that were excluded in the MOMS trial. Of course, in open surgery, these exclusion criteria have also evolved. And this, of course, leads to ethical questions. As maternal morbidity decreases and may reach almost 0, does this imply that the indications for fetal myelomeningocele repair have to be extended, and that termination of pregnancy for severe medical reasons, which is in Belgium, like in France, usually done when the obstetrician makes the diagnosis at 18 or 20 weeks. It's only a question, but how good must the outcome be to change this very important legal and ethical question? So finally, some thoughts for the future. We as pediatric neurosurgeons have to stay involved also in fetoscopy, also when we don't personally do every surgical act. Second, we have to, for future research, we all have to contribute with our results, and we need some kind of a global uniform registry, and perhaps this is a role for the ISPN, even though the procedures themselves are still evolving and improving. And if a registry does not demonstrate superiority, perhaps in 5 or 10 years, we will need a second MOMS trial in the long term. Thank you for your attention, and thank you for letting me share these thoughts.
Thank you very much, Frank. That's excellent talk. I wanted to, you presented very nice data on the learning curve and statistics on when people become competent with this procedure. But I wanted to ask you sort of a more just to tell us about your personal experience anecdotally, what you've been going through, how you've trained to develop skills in this procedure. And do you really believe that it takes 50 fetoscopic cases to become competent? Because that's an exceptionally high standard. And I don't know if that makes it prohibitive to have anybody do this.
Yes, well, first for open surgery, I've done my first procedure for myelomeningocele postnatal in 1987. So I've done a few hundred before doing the first fetal. I did not have the impression that I needed 30 cases to feel competent. Still, when we look at our results, I think the first 15 are not as good as what we had later. That's one thing. Fetoscopy, we have done in Leuven 3 cases, but I was there and I guided the obstetricians and the fetal surgeons who manipulated the instruments. I did not feel competent to make sutures in this in this laparoscopic procedure. And I think a few young neurosurgeons need to be trained in that, and perhaps they have to do 6 months in abdominal surgery to learn to make sutures.
Okay,
but not everyone can do this.
Thank you.